Welcome back to the podcast. I'm Dr. Khan, and today we're diving into the axilla, specifically the axillary lymph nodes. Now, I know what you're thinking. Oh, great, a list of 20 to 30 tiny beans to memorize. But stop right there. These aren't just beans. This is the drainage system of the upper limb and the breast. If you want to understand how breast cancer spreads or why a patient's arm might swell up after surgery, you have to master this territory. Think of the axilla as the grand central station of the lymphatic system. Everything from the arm, the chest wall, and the back has to pass through these gates.
That's a great analogy, Dr. Khan. But for the boards, we need to be a bit more surgical with our definitions. While there are dozens of nodes, they are precisely organized into 6 distinct groups: the pectoral, subscapular, lateral, central, infraclavicular, and apical groups. These aren't just random names. They tell you exactly where they sit and what they drain. If you're looking at a multiple choice question about breast cancer metastasis, the pectoral group is usually your starting point.
Exactly. Let's break down those first 3 peripheral groups. I like to think of them as the outer security checkpoints. First, you've got the pectoral group. These are anterior, hugging the lower border of the pectoralis minor. Why does this matter clinically? Because these nodes drain about 75% of the lymph from the mammary gland. If you feel a hard, fixed node here, you're thinking breast pathology immediately.
High yield point there. Pectoral is anterior. Then we have the subscapular group, which is posterior. These sit in front of the subscapularis muscle and drain the back down to the iliac crest. And third, the lateral group. These are tucked along the medial side of the axillary vein. They handle almost the entire upper limb. So if your patient has an infected cut on their hand, the lateral nodes are the ones that are going to be tender and swollen.
Right, so we've got the front, the back, and the arm. Now, where does all that fluid go next? It hits the central group. Think of this as the main lobby of the station. It's located deep in the axillary fat. It collects the commuters from the pectoral, subscapular, and lateral groups. It's the second tier of the drainage system.
And from the central group, the lymph moves up to the apical group. This is a big one for exams. The apical nodes are located at the very top, the apex of the axilla, right at the lateral border of the first rib. This is the final common pathway. Everything eventually drains here before heading into the subclavian lymph trunk or the right lymphatic trunk. If cancer reaches the apical nodes, it's basically at the exit door, ready to enter the general circulation via the thoracic duct on the left or the right lymphatic duct.
And don't forget the special guest group, the infraclavicular or deltoid pectoral nodes. These are technically outside the axillary pyramid, sitting in that little groove between the deltoid and the pec major. They're unique because they receive superficial vessels from the lateral side of the arm and hand that actually bypass the other groups. Why does this matter clinically? Well, if a patient has a melanoma on their thumb, you might find a skip metastasis in the infraclavicular nodes, even if the rest of the axilla looks clear.
That is a classic clinical trap for students. Now we have to talk about how surgeons actually look at these. They don't usually use the anatomical names we just listed. They use levels. Level 1 nodes are lateral to the pectoralis minor. Level 2 are deep to the muscle. Level 3 are medial or superior to it. For the USMLE, remember that the pectoralis minor is the landmark. The higher the level, the more advanced the spread of breast cancer.
And that leads us to the big surgical question: radical mastectomy. When a surgeon removes the breast and the axillary nodes in block, they have to be incredibly careful. I always tell my residents that being the doctor of choice for a patient means knowing exactly what's at risk in that axillary fat. If you're too aggressive and damage the long thoracic nerve, you've just given your patient a winged scapula. They won't be able to comb their hair because they can't rotate the scapula to raise their arm above 90 degrees.
And let's talk about the most common post-surgical complication, lymphedema. When you remove those lateral and central nodes, you're basically tearing up the highway that the fluid from the arm uses to get back to the heart. Without those nodes, the fluid backs up. The arm becomes heavy, swollen, and prone to infection. It's a life-altering condition for many breast cancer survivors.
It's like a massive traffic jam where the bridge has been demolished. There's nowhere for the fluid to go. This is why modern surgery has shifted towards sentinel node biopsies. Instead of taking out 20 nodes, we find the very first node in the chain, the sentinel, and test it. If it's clear, we leave the rest of the grand central station intact, saving the patient from that debilitating lymphedema.
Precision is everything. To recap for the exam, you have 6 groups. Pectoral drains the breast, subscapular drains the back,
Lateral drains the arm. They all go to the central group, then the apical group. The infraclavicular group is the outlier for the lateral arm. And always watch out for the long thoracic and thoracodorsal nerves during an axillary dissection. Beautifully put, Sarah. Clinically, the axilla isn't just a space, it's a crossroads. Whether you're dealing with an infection, a trauma, or a malignancy, these nodes tell the story of what's happening in the upper limb and thorax. The takeaway for today: the pectoral nodes are your breast sentinels, the apical nodes are the exit point, and the pectoralis minor is your surgical map for the levels. Thanks for joining us, and we'll see you in the next session.